of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Marco Capecci from Switzerland, and he's going to lecture us on frontiers in ITP treatment. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus dedicated to life and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and Team Zydus, Mr. Yash, Mr. Kalpesh and the Team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Lieutenant Colonel Dr. Ranjit Matthew Varghese from Pune, our guest speaker for the day, Dr. Marco Capecci from Switzerland. All our discussants who are themselves very eminent hematologists as well as pediatric hematologists, and you participants for spending a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 29th of June 2024, from 7 p.m. Indian Standard Time and 8:30 a.m. Central Time, we have Dr. Prashant Kapoor from Mayo Clinic, Rochester, speaking to us on Waldenstrom macroglobulinemia. And the following day, that is Sunday, 30th of June 2024, from 11:30 a.m. Indian Standard Time and 8 a.m. Denmark time, we have Dr. Lena Specht from Denmark speaking to us on palliative radiotherapy in hemato-oncology. Let me introduce our discussions for the day, and here displayed in alphabetical order. To start with, we have Dr. Abhilasha S. from Belgavi, Karnataka, Dr. Abhinit Deshmukh from Sahyadri Hospitals, Pune, Surgeon Commander Dr. Ashok K. Yadav from Armed Force Medical College, Pune, Colonel Dr. Ashok Meshram from Command Hospital, Kolkata, Dr. Bhavani Mandwa from IMS and Some Hospital, Bhubaneswar, Dr. Bilal Qazi from Apollo Multispecialty Hospital, Kolkata, Dr. Dipjot Pusti from Tata Steel Medical Hospital, Jajpur, Odisha, Dr. Dipti Jain from Nagpur, Dr. Dinusha Chaturani from Great Manchester, UK, Dr. Indrani Mondal from Institute of Hematology and Transfusion Medicine, IHTM, Kolkata, Dr. Krishnanathanam Kannan from Sundaram Medical Foundation, Chennai, Dr. Kunal Chatani from Nagpur, Dr. Malini Garg from Homi Baba Cancer Hospital, Varanasi, Dr. Manoj Toshniwal from SIDCO, Aurangabad, Dr. Manthan Kathrotia from Apollo Hospital, Ahmedabad, Dr. Mona Vijayaran from SGPGI, Lucknow, Dr. Nakul Tikare from AIMS, Bhubaneswar, Dr. Nidhi Jain from Zydus Hospitals, Ahmedabad, Dr. Nikhil M. Kumar from Fortis Memorial Research Institute, Gurugram, Dr. P. Raghuveer from King George Medical College, Lucknow, Dr. Ramaswamy NV from Hematology and Bone Marrow Transplant Unit, Aster Medicity, Cochin, Kerala, Dr. Shiva Kumar Komraveli from Omega Hospitals, Hyderabad, Dr. Shruti Kakkar from Dayanand Medical College and Hospital, Ludhiana, Dr. Sonali Mohapatra from AIMS, Bhubaneswar. Now it's a time to introduce our special guest and chief guest for the day. We have with us Lieutenant Colonel Dr. Ranjit Matthew Varghese from Pune. Lieutenant Colonel Dr. Ranjit Matthew Varghese is clinical hematologist at Command Hospital, Pune. He did his MD in internal medicine from AFMC, Pune. This was followed by DM in clinical hematology from AIMS, New Delhi. Following are the list of his recent awards achieved by him, he received API All India Medicine Quiz, the Epicon, Hyderabad 2016 with first prize, Annual Hematology Quiz by Delhi Hematology Group in the year 2022, first prize, Best Case Report ISHBT Northwest Chapter, PGI Chandigarh 2022, again the first prize. His areas of interest include bone marrow transplant, myeloproliferative neoplasms, as well as hemoinflammatory syndromes. And it's my privilege to welcome Lieutenant Colonel Dr. Ranjit Matthew Varghese to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Ranjit Matthew Varghese. Dr. Ranjit, are you there?
Yeah.
We cannot hear you. Neither can we can see you.
Is it okay?
Oh. Some... Yes.
Yeah, am I audible now?
Yes, you're audible. Please go ahead.
Yeah. Sorry, unfortunately, the internet is slightly erratic because of the ongoing rains here in Nagpur. So, good morning, everyone, and greetings of the day to all our international viewers. At the very outset, I would like to thank Dr. M.B. Agarwal and the Mumbai Hematology Group team for inviting me uh, to open this part of webinar. So my first contact with MHG Group came in 2013 when I was a first year resident in medicine. So it was through a book. So I found it very interesting. And later on, I came to know uh, what does MHG do. So in a nutshell, MHG generally promotes the younger specialists like me and many of my colleagues who are here attending the meeting also. They provide a platform for the younger ones to come and speak up and gain confidence from speaking at a very large platform. So, and if you see through the history, many of them have walked through that corridors of MHG are now the renowned stalwarts of the field of hematology in India. So the responsibility bestowed upon me by Professor Agarwal is to share the words of wisdom. That itself is a big ask for me because my field in this hematology field is just less than 5 years, which is inclusive of my DM training in at AIMS. So I would like to share a few things which I have gained through my period in this field of practice. So hematology, if you ask me, it is a very exciting branch of medicine. Why it is exciting? Something we can compare it as something akin to a space program of the medicine, because with the recent advent of molecular diagnostics as well as targeted therapy, it is becoming more and more interesting, and the outcomes of the diseases have improved as compared to the older days. So why it is exciting? If you see the patients who come up in hematology practice, they are mostly the sickest of the sickest, particularly the leukemias and the lymphomas. They would be sick to the bone and they would look upon you as a specialist to save them from their sufferings. And many of the times we would be able to deliver, and as equally, many of the times we fail also. So it is not a very easy field to practice. However, it is an exciting field because it gives you a mixture of a lot of interconnecting specialties to our practice. So why this branch is very exciting? If you wake up every day, there is one new molecule which is launched or a new article in a particular field which is come up. So to keep abreast with the knowledge, you should be updated and you should be reading every day. And the other thing which I have noticed after practicing hematology, my perspective of seeing patient has changed. Particularly if we see today's talk is on immune thrombocytopenia. So ITP, it is just a starting point of some disease, and later on the disease keeps on evolving, and it shows its true colors in the future. So this thing is like what we see today is not tomorrow. So the diseases evolve, the patients change, the diagnosis which you gave at the initial may not be the final diagnosis. So all these things make it a very exciting package. And by treating such patients, we sail through a lot of uncharted waters, which we have never come across in our situation. And secondly, we need to be adaptable or malleable to the situation. That is, we can only practice in a resource constrained setting like ours. We can only practice according to the financial commitments by the patient. Many of them would be poor. And what is the financial capability of your institution, or how much you can explore upon the treatment options? So it is not like you are given a certain patient and you can only treat accordingly. So by counseling that patient, you can get XYZ treatment, and this is the state of the art treatment, which the patient may not be affordable. So you need to be adaptable to the situation and malleable so that you can understand what is the economics of the patient and what is the economics of your institution and change your practice accordingly. So the other important thing which I have come across is, if you treat the patient as your one of your own precious one, the things or the mistakes which you are going to commit would be less. And counseling the patient is very important in the current day of practice, especially with legal suits, which is growing. So if you counsel them and do not give them unexpected expectations, so you can treat them accordingly, and you can arrive at a final conclusion at a very fast time. So my final this thing would be truthful in whatever you are doing, particularly, especially in counseling patients. We say that many of the patients would be like, many of them would come to me also, like some would say that myeloma as a transplant, it is a panacea or a cure for the disease, which unfortunately is not. We all know that it is just prolonging your survival and deepening your responses. So my request to the younger generation would be not to give them unexpected, unexpected possibilities of a cure or anything, but to be truthful to the patient and to the patient attenders also, because finally it is them who is going to be at the end of your treatment, and they are the ones who are actually going to suffer because of your statements. So my last thing would be, the patient can be interpreted in many ways. Like as I said earlier, like patients can start from one point and get on to another point. So whenever a patient is referred to you, or if a patient is self-referred, do not belittle the physician or the specialist who the patient was taking treatment from the last center. And rather than, you should say that the patient was being treated at a correct point of time, because at that point of time, the disease which was there, he has treated it correctly. So I would like to thank Dr. Amit and the MHG team for giving me this opportunity. And thank you so much for inviting me as a guest speaker. Over to you, Dr. Amit.
Thank you, Dr. Ranjit Matthew Varghese, for that wonderful words. It was really kind words from you, and it's a real world experience you really brought out to our younger colleagues, and this will really help them in the near future. Thank you so much for being with us, and what a wonderful kind words you said today. Thanks a lot.
Thank you so much, Dr. Amit.
I'll share my screen again. So it's now time to introduce our guest speaker for the day. We have with us Dr. Marco Capecci from Switzerland. Dr. Marco Capecci has received his degree in medicine and surgery at the University of Pisa and Sant Anna School of Advanced Studies in Pisa. He received his postgraduate degree in hematology at University of Milan. He is specialist in the field of hemostasis with a specific interest in venous thrombosis and platelet disorders. He conducts his clinical and laboratory research activity in the field of coagulation disorders with a focus on hypercoagulability. Earlier, he has worked with Professor Flora Pevandi at the Angelo Bianchi Bonomi Hemophilia and Thrombosis Center at Fondazione IRCCS CA Granda Ospedale Maggiore Policlinico, Milan, Italy. And today he's with us and he's going to lecture us on frontiers in ITP treatment. Well, thank you so
Yes, Dr. Capecci, I think you can start your screen share and start your lecture. You're muted.
Can you hear me now?
Yeah, sure. Please go
Okay,
ahead.
perfect. So good morning, everybody. And first of all, I would like to thank Professor Agarwal for this kind invitation. And as some of you may remember, I gave a couple of lectures for your group a couple of years ago on thrombotic microangiopathies. But for this time, we decided together with Professor Agarwal to switch from TTP to ITP. And I will talk in the next hour about the new treatment options in immune thrombocytopenic purpura. But before starting with treatment, we need to remind the pathophysiology of the disease. And in ITP patients, it all starts with an immune dysregulation. And especially, there is a dysregulation in the T cell compartment. In fact, there is an imbalance in the subpopulation of the T helper lymphocytes with a downregulation of the Th2 and the Treg, which have immunosuppressive properties. On the other hand, there is an upregulation of the Th1 and Th17 subpopulation, which have immunostimulating properties. And these T lymphocytes, this regulation leads to the proliferation of oligoclonal auto-reactive B cells that, at the end, results in an increased production of autoantibodies. These autoantibodies are directed in ITP patients to the surface, to the platelet surface, to glycoproteins expressed on the platelet surface, and these platelets that are opsonized are more rapidly destroyed by the macrophages, mainly in the spleen. And this destruction process takes place with an Fc receptor-dependent mechanism. These autoantibodies, on the other hand, also binds to the megakaryocytes in the bone marrow and destroy the megakaryocytes and reduce the platelet production. The aberrant platelets that are still produced by the megakaryocytes undergo an aging process and a decellulation process which is more quick, and these aberrant platelets are more fastly destroyed in the liver with an Fc-independent mechanism by the binding to the actual moral receptors. At the end, there is also the downregulation on the Treg, which in turn results in an increased activity of the cytotoxic T cells that finally destroy both the megakaryocytes and the platelets. So before talking about treatment, we should have in mind very clearly that ITP disease is divided into 3 clinical phases. We talk about the newly diagnosed ITP within the 3 months after diagnosis, a persistent phase between 3 months and 12 months, and the chronic phase after 1 year from diagnosis. And this differentiation is very important because different drugs are approved in different phases of the disease. There are currently 3 guidelines, 3 international guidelines available on the treatment of ITP, the American Society of Hematology and the International Consensus Guidelines, which have been published both in 2019. And there is a more recent guideline published in 2023, which comes from the German-speaking countries in Europe, Austria, Germany, and Switzerland. And this is the most updated one. In this slide, you can see the evolution of treatment of ITP in the last century. It all started in 1920s when the first splenectomy performed in an ITP patient showed activity. In the subsequent years, intravenous immunoglobulins, the use of corticosteroids, the use of classical immunosuppressive drugs such as azathioprine, mycophenolate mofetil, and others. The use of the anti-D serum showed activity in ITP patients. In 2000, rituximab showed the activity in disease control. And in around 2010, the thrombopoietin receptor agonist has been developed. And the first that has been approved in Europe by EMA was romiflostim in 2009. And in the subsequent years, eltrombopag was approved first in adults and later in children. And the last one, avatrombopag, have been approved in 2021 in Europe. In 2019, EMA approved fostamatinib, which is the first-in-class SYK inhibitor. And in the last year, there are many other drugs that are under development. So this slide shows you the current indication of treatment in ITP. And as you can see, the first line treatment after new diagnosis is still represented by corticosteroids. You can see here that IVIG can be used at any time during the disease course. The second line treatment are currently represented by the two thrombopoietin receptor agonists, L-Thrombopag and romiplostim, that can be used sudden after corticosteroids when the patient is refractory of it, if it recurs rapidly. And there are other second-line treatments that can be used, which are other immunosuppressors, danazol, dapsone, all drugs, but that can be still used in some subsets of patients. And there is also rituximab. Rituximab is considered in all the international guidelines for ITP treatment, but rituximab has not been approved by any of the regulatory agencies around the world for use in ITP. So use of rituximab is always off-label in this setting. For chronic patients, there are other options now available, which are the third approved TPO-RA, which is avatrombopag, the first-in-class SYK inhibitor fostamatinib, and in some specific cases, splenectomy can still be considered an option. So it is very important to look at these rates of response after the first line of treatment and the second line of treatment. And you can see that the initial response rates are from 60 to 80%. So quite high. But if you look at how many patients maintain a sustained response after discontinuation of treatment, you can see that these figures drop down from 80 to around 30, 35, 40% for dexamethasone, and they drop down to 30% at 1 year for TPO-RAs, and to 15, 20% at 5 years for rituximab. So there is the need to improve our capability to treat these patients, to increase the initial response, but especially to increase the sustained response. And in the rest of my presentation, I will try to show you which are the possible new treatments that can become available in clinical practice in the next year. So first of all, what can we do to improve our ITP treatment? First of all, we can intensify the first line of treatment. And during the last 15 years, there have been many attempts to do so. Many studies added to the first line treatment with corticosteroids, other immunosuppressors such as rituximab, cyclosporine, mycophenolate mofetil, but also a small study also tried to add L-Thrombopag together with rituximab. And these strategies led to an improved in sustained response at 6 months that's from around 35–40% reached a 60% rate. It is very interesting, the possibility to advance the use of the TPO-RA in first line. And there is currently a phase 3 trial in newly diagnosed ITP patients, which is ongoing in Europe and North America, which is the RODEX study, in which the use of romiplostim TPO-RA is evaluated together with dexamethasone, is evaluated against dexamethasone. And we look forward to see the results of this study in the next years. Another way to improve our ITP treatment is the use of new TPO-RA. There are many under evaluation. I will not talk about avatrombopag because it's now included in clinical practice, but if you want, we can talk about it later during the question and answer session. But I would like to show you some real-world data that have been presented last week at the European Hematology Association meeting in Madrid. These are two registries, one from Europe and one from the United States. And these registries in the use of avatrombopag confirmed the higher response rate that were showed in the randomized controlled trials. And they also show an important thing, indeed the fact that avatrombopag is effective also in patients that were previously treated with another TPRA. So giving the proof of concept that if we have a patient treated with TPRA that become resistant, you can switch to another TPRA and it may be of some benefit. There are other TPRA under development. Lusotrombopag is not at this point is not licensed for use in ITP. It is only possible to use it in patients with chronic liver disease and thrombocytopenia that should undergo invasive procedures. And there are other two drugs, other two TPRA, which are available in China, etrombopag and the recombinant human TPO. This is very interesting because it's the only one that potentially can be used during pregnancy, because all the other TPRA are not licensed for use in this setting. At the EHA has been also presented this interesting study that tried to add to TPRA all-trans-retinoic acid, and the goal of the aim of this study was to try to obtain a sustained response of treatment, to increase the sustained response of treatment. And to do so, it is very important to obtain a sustained platelet response during treatment. And it is also important that the platelet count remains stable during treatment. And these two conditions are essential to achieve a sustained response of treatment after discontinuation of the treatment. These studies have enrolled so far 13 patients. They were on TPRA, and they show the platelet count fluctuation of greater than 100,000. The authors added ATRA at the dose of 20 milligrams once daily, and they showed that the addition of ATRA showed an efficacy in resuming the platelet response in around 80% of patients. Two severe adverse events, headache, led to the discontinuation of the drugs. Another way to improve ITP treatment is the reduction of splenic catheresis. And as you can see here, this can be done by inhibiting the macrophages, the phagocytosis of the macrophages, mainly in the spleen, and reducing the antibody-dependent cell-mediated cytotoxicity of the opsonized platelets with the antiplatelets autoantibodies. There are two different ways to reduce the splenic catheresis: SYK inhibitors or FcRn blockers. Let's talk about SYK inhibitors. SYK is the spleen tyrosine kinase that is expressed both in the macrophages but also in the B lymphocytes. In the macrophages, SYK is implicated in the intracellular signaling downstream the Fc gamma receptor. And any inhibition of SYK results in inhibition of platelet phagocytosis and destruction. But SYK is also expressed in B lymphocytes. It is implicated in the downstream intracellular signaling pathway after the B cell receptor. And its inhibition in B lymphocytes results in the reduction of B cell activation and in reduction of antiplatelet antibodies production. Again, the first-in-class SYK inhibitor was fostamatinib. I will not talk about that because it's included in the current clinical practice. These are the registrative trials. But I would like to show you some real-world data from the EHA meeting. This is a registry in Spain, and it enrolled 138 patients. They were all heavily pretreated patients with a median number of previous lines of treatment of 4, and the results showed an overall response rate of 83% with 54% CR rate and a median time to platelet response of 11 days. So confirming again the results of the clinical trials. The adverse events were reported in half patients, and they were mainly diarrhea and hypertension, and they were mainly most grade 1 or 2 with no grade 3 or 4 toxicities. Another strategy is to combine different drugs, and in this study, they try to combine the SYK inhibitor fostamatinib together with the TPRA avatrombopag. This is a study conducted in Norway, Europe. It enrolled so far 18 patients. They were on avatrombopag at the maximum dose of 40 milligrams. And after 2 weeks, the patients that didn't reach a platelet count greater than 30,000 were enrolled in the study. The overall response rate was very high, 78%, with 7 complete response, and no grade 3 or 4 toxicities were reported. So these strategies to combine ATP-RA and an immunosuppressive drugs is very interesting and very appealing, and could optimize the treatment of ITP, because at the same time we address different pathophysiological pathways. On one hand, we increase the platelet production, and on the other hand, we reduce the platelet destruction with immunosuppressive drugs. And it is the same concept that has been considered in the RODEX trial, which combine ATP-RA romiplastim together with an immunosuppressive drug, which is corticosteroids in the first line, and is currently ongoing. There are also new SYK inhibitors. This is a phase 1 study on the use of sovleplenib. Preclinical studies shows that sovleplenib has an increased SYK selectivity as compared to fostamatinib. This study has been conducted in Western patients, and it was a dose-finding study for to go ahead with the phase 3 trial. The patients should have had at least 1 prior treatment, and patients that were exposed previously to a SYK inhibitor were excluded from the trial. This drug is currently evaluated also in 2 clinical trials in China, 1 phase B and 1 phase 3 trials, that showed so far an higher overall response rate with a good duration of response rate. So moving on, if we still talk about to reduce the splenic catheterizes, there is also another mechanism that we can use, which is FcRn blockers. And FcRn blockers act, in this slide, I will show you the mechanism of action of FcRn blockers, but I feel it to be very interesting. FcRn blockers are usually bind with a high affinity to the neonatal receptor of the Fc fragment of the IgG, which is expressed in the inner membrane of the endosome. And in this way, they prevent the binding of autoreactive IgG to neonatal Fc receptor. And in this way, they reduce the recycling of the auto-reactive IgG, and they increase their degradation in the lysosome. So overall, FcRn blockers reduce the recycling of auto-reactive IgG and increase their degradation. So it acts like a sort of medical plasmapheresis, and we can say that it reproduces the same mechanism of action of intravenous immunoglobulin, but with a higher performance. By reducing the IgG recycling, FcRn blockers are responsible of the reduction of IgG plasma levels, so they can induce a transient hypogammaglobulinemia, and so they can increase the risk of infections in ITP patients. The first-in-class FcRn blocker is represented by efgartigimod. Efgartigimod can be administered IV or subcutaneously. The first phase 2 study was conducted on 38 relapsed refractory ITP patients. There were 2 doses of the drug that were investigated. The drug was administered once weekly for 4 weeks, and it was evaluated against placebo. This drug showed a rapid reduction of total IgG of around 60%, a rapid reduction of the bleeding rate, and a rate of the platelet increase greater than 50,000 for at least 2 occasions of 46%, and a rate of increase of platelet greater than 50,000 in more than 10 cumulative days of 31%. You can see here the recently published phase 3 trial, the advanced IV, which included 131 patients with relapsed refractory ITP. The dose that has been used from the dose-finding part of the phase 2 study was 10 milligrams per kilo. It was administered once weekly for 4 weeks, and then depending on the platelet response every week or every 2 weeks. It was again evaluated against placebo. And as you can see here, patients that were treated with efgartigimod showed a rapid drop of the total IgG in the plasma, and consequently a rapid increase of the platelet count. So the sustained response, platelet response, was about 22% compared to 5% in the placebo arm. But we have to consider for this study that around 50% of patients were on concurrent treatment. The most important adverse event was represented by headache, and there is a phase 3 trial ongoing on the evaluating the subcutaneous formulation of the drug. There is another FcRn blockers under evaluation, which is rozanolixizumab. It could be administered IV or subcutaneously. This is a phase 2 study, which is a dose-finding study. And again, it shows a good activity in reducing the total IgG plasma levels and to increase the platelet count after administration. The overall response rate varies from 35 to 65%, depending on the dose that has been used, and the time to response is shorter with higher doses. Again, the adverse events are mainly represented by headache and bone ache, and there is a phase 3 trial ongoing. So let's move on to another way of treating ITP patients with this, which is complement system inhibition. As you know, around 80% of ITP patients show on their platelet surface the complement fixed, and especially the C3b component of the complement cascade, which opsonizes platelets and increase the rate of phagocytosis by macrophages via the complement receptor CR1. And 50% of ITP patients, in 50% of ITP patients, it is the classical pathway of the complement system that is activated, so that an inhibitor, a drug which inhibits the C1s subunit of the C1 complex of the classical pathway has been developed. And this is sutimlimab. Sutimlimab is an IV drug. It has been evaluated in a phase 1 study recently published. It has been enrolled 12 patients with relapsed refractory ITP. The drug was administered on day 1, day 8, and then every 2 weeks. And as you can see here, the mean platelet count at the basal time point was 25,000. After 24 hours, it increased to 54,000, and at day 8, it increased to 139,000. The overall response rate, defined as a platelet count greater than 50,000 on 2 consecutive samples, was 42%, with a CR rate of 33% and a durable response of 42%. The median time to platelet count greater than 50,000 is only 2 days. And as you can see here in the graph, there is a good correlation with between platelet response and the inhibition of the complement, which is expressed by this blue line. And the most important adverse event is still represented by headache. Lastly, there is another way to improve our ITP treatment, which is the inhibition of autoantibodies production. We currently do so with corticosteroids, with classical immunosuppressive drugs, and especially with rituximab. But there are 2 different ways that can be used to inhibit autoantibodies production, which are represented by BTK inhibitors and by targeting the plasma cells. Coming to BTK inhibitors, we all know that BTK is expressed in the lymphocytes, and the inhibition of BTK in the lymphocytes results in a reduction of antiplatelet antibody production. But BTK is also expressed in macrophages. It's downstream of the SYK protein, and an inhibition of BTK in macrophages results in reduced platelet phagocytosis. Rilzabrutinib is an oral BTK inhibitor, a covalent reversible BTK inhibitor, as it has been evaluated in a phase 1/2 study in relapsed refractory ITP patients. 60 patients were enrolled, and many different dosages were used, but the final dose was 400 milligrams twice a day. And as you can see here, the rate of platelet response defined as a platelet count greater than 50,000 on 2 consecutive samples, together with an increase of at least 20,000 from baseline, was around 40%. The adverse events affected mainly the GI tract, the gastrointestinal tract, and the way they were all grade 1 or 2 with no grade 3 or 4 toxicities, and they were all transient. This is the recently published results of the long-term extension study of the same study previously presented regarding 16 patients that responded to the initial phase of treatment. And as you can see here, also in long-term follow-up, there is a sustained platelet response. Some data coming from the DHA meeting last week. The LUNA-3 trial is the phase 3 trial of rilzabrutinib in ITP patients. It is compared to placebo. Patients with persistent and chronic ITP that were previously treated has been enrolled. A total of 202 patients has been enrolled, and they were very heavily pretreated patients with a median number of previous lines of treatment of 4, but the range is from 1 to 17. And these data are expected to come out in the next months, and the rilzabrutinib is also expected to be approved within 2024, both by FDA and EMA. There are also other BTK inhibitors that are under evaluation, which are orelabrutinib, ibrutinib, and zanubrutinib, and data will come out in the next future. So, to inhibit the autoantibodies production, there is also another way, which is plasma cell targeting. And we can target plasma cells in 2 different ways with proteasome inhibitors. We all know bortezomib for multiple myeloma patients. There are currently trials evaluating bortezomib together with rituximab in both newly diagnosed or relapsed refractory ITP patients. Another way to target plasma cell is to use anti-CD38 antibodies. And this concept comes out considering the reports that in patients with refractory immunocytopenias, not only ITP, but also hemolytic autoimmune hemolytic anemia, there is a residual number of lymphocytes that express CD138, so they can be targeted by anti-CD38 strategies. And this is just a clinical case report, but shows very well that these kind of patients that had a very low, a very severe thrombocytopenia were treated with many different drugs with no response, and a treatment with daratumumab showed a rapid platelet response that remains sustained over time. There are also another anti-CD38 monoclonal antibody, which is mezagitamab, TAK-079, which has been recently evaluated in a phase 2 trial that enrolled persistent and chronic ITP patients. It is a subcutaneously administered drug. It has been evaluated versus placebo. There are the results of this study has not been yet published, but there is a phase 3 ongoing. There is a phase 3 trial that has been planned and should start in early 2025. And I hope I will participate in this study with in my center. And there is a very recent monoclonal antibody against anti-CD38, which is CM313. This study has been published this week on the New England Journal of Medicine, and it is a phase 1/2 study. It is an IV drug, which is administered at the dose of 16 milligrams per kilo every week for only 8 weeks, and then the drug is stopped. The study enrolled 22 patients and showed an overall response rate of 95% with a median time to platelet count greater than 50,000 of only 1 week and a median duration of response of 23 weeks, which lasts also after the stop of the treatment. The most important adverse events were represented by infusion reactions and upper respiratory tract infections. I would like to focus on the fact that some of these patients lose their response, even if they responded at first. And this is mainly due to the fact that some plasma cells undergo a process of CD38 internalization, so that they become refractory to anti-CD38 and they continue producing antiplatelet antibodies. And this mechanism is responsible for the relapse after an initial response to this drug. So before coming to the conclusion of my presentation, I would like to show you some new and I think very interesting data on the possible role of the BAF pathway in ITP pathophysiology, and this could represent a new molecular target for ITP patients. So BAF is the B-cell activating factor, also known as BLyS, the B lymphocyte stimulator. And this pathway seems to be responsible to resistant to anti-CD20 treatment and also to splenectomy. We do know that the response rate to rituximab is of around 40%, but there is 60% of patients that are primary refractory to the disease, to the drug. And there are also patients that initially respond to rituximab, but at the second time they relapse after an initial response. And indeed, the response rate at 5 years is only 20% and dropped from this figure to this figure. And the mechanism of resistance that may explain the relapse after an initial response is the production of B cells that are resistant to anti-CD20. And this may happen with two different mechanisms. One mechanism is represented by CD20 internalization by B cells, and another mechanism is represented by trogocytosis of CD20 by Fc gamma R expressing cells, especially macrophages. And both these mechanisms result in the production of B cells that don't express CD20 anymore on the surface, and therefore they are refractory to anti-CD20 treatment. And these two mechanisms seems to be stimulated by the activation of BAF receptor pathway. On the other hand, primary resistance to anti-CD20 treatment is mainly due to the presence of long-living plasma cells in the spleen. When we treat patients with anti-CD20, we increase the level of BAF, and this increase of the BAF level in the plasma cell niche leads to the production of a higher amount of long-lived plasma cells that therefore still continue to produce anti-platelet antibodies, and therefore they are resistant to anti-CD20 because they don't express CD20 on their surface. So a possible strategy of treatment could be to use at the same time an anti-CD20 treatment together with an anti-BAF treatment, so that to lower the BAF increase and to reduce the transformation of plasma cell in long-lived plasma cells. The BAF pathway seems also to be implicated in the resistance to splenectomy, and I will show all these three different mechanisms of resistance in this slide. As you can see, if one patient is treated with rituximab, there is an increase in BAF, and this increase in BAF leads to an increase of the splenic long-lived plasma cells, and this accounts for primary failure of rituximab, as previously shown. But BAF expression, increased expression, also leads to the production of CD20 negative memory B cells that are rituximab resistant, and they still remain in the spleen niche. At some point, around 6 months after the last dose of rituximab, newly naive B cells are generated in the bone marrow. They migrate into the germinal center in the spleen, and they are primed at some extent by these rituximab-resistant memory B cells, and they promote the production of plasma cells that are still able to produce anti-platelets autoantibodies. And this mechanism accounts for the relapse after initial response to rituximab. But if we undergo splenectomy, especially after the use of rituximab, we reduce the rate of success, because also in the bone marrow, the increased levels of BRAF may increase the production of long-living plasma cells that will continue producing anti-platelet antibodies despite splenectomy. So the BAFF-BAFF-R pathway can be targeted, and ianalumab is a monoclonal antibody, an IV monoclonal antibody that targets the BAFF receptor. The BAFF receptor is selectively expressed in B cells, and therefore this drug reduces the activity of the memory B cells, reducing signaling and inducing antibody-dependent cell-mediated cytotoxicities. And ianalumab also reduces the differentiation of plasma cells in long-living plasma cells. There are 2 trials ongoing on the use of ianalumab in ITP patients, one in first line together with steroid, and one in second line in patients that fail steroid in first line together with a thrombopag. However, BAFF receptor is not expressed in long-living plasma cells, so they can continue their activity and continue for the pathophysiology of the disease. So that another option could be to directly target the BAFF, both the soluble form and the membrane form. Belimumab is the monoclonal antibody, which is administered IV and is approved currently for lupus erythematosus systemicus, and is currently under evaluation in a phase 2b study together with rituximab, and the preliminary results on 15 patients showed an overall response rate of 80%, which is much higher than rituximab alone. So, in coming to the conclusion, we should have in mind that the final aim of ITP treatment is stopping treatment and to reduce the burden of long-term treatment. And to reach this goal, it is very important to achieve a sustained response that should be maintained off treatment. And all these new strategies that I showed you during my presentation should be included in clinical practice in the next years, having in mind this final aim for our ITP treatment. So this was my last slide, and thank you very much for your attention, and I will be available for questions, if any. Thank you.
Thank you, Dr. Marco Capecci, for a wonderful lecture. As always good to hear to you. And
Thank
the
you so
newer
much.
generations and of the treatment brought today was, mesmerizing. It was eye-opening for all of us, especially the BAFF pathway, what you described. That was really fantastic. Thanks a lot.
Yeah. It was really. I was really interested in this pathway because it's more and more data are coming out in the last years. And at EHA last week there was a specific session this topic because, as you can imagine, also drug companies are very interested in this pathway because they could really change the landscape of refractoriness to treatment, to currently available treatment in ITP. So we look forward to receive the results of the ongoing trial on this topic.
Thank you so much. I request all our discussants to please put the raised signs so we can start our question answer session with Dr. Marco. Yes, Dr. Malini, your question, please.
Good morning, sir. Thank you for the wonderful talk. The new frontiers, the new treatment options are really amazing. Looking at for chronic ITP when we are left with no options available. So, sir, my question to you is, in cases with ITP with ANA positivity, in 20 to 30% of the females, ANA is being said to be positive. So, in those cases, apart from corticosteroids, IVIG, So, is there any role of these drugs like azathioprine or hydroxychloroquine to be added from frontline only, or to wait later and then add?
Yeah. Of course, if you look at the current clinical guidelines, there is no guidance, for these specific situations. But first line is always corticosteroids so far. And even in our center, we are used to start only with corticosteroids because most of the patients just have a response after this line of treatment. But as a second line, even though now the second line treatment is represented by TPO-RA, I would suggest for patients that have a concomitant autoimmune disease, and this is more often, as you mentioned, in female patients in middle ages, to consider another immunosuppressive treatment, because this may increase the chance of a sustained response over time. So in these cases, you can consider to use rituximab, but there are some data that shows that rituximab is more effective to obtain a sustained response, especially in patients that have antiplatelet antibodies that are detectable, for example, or in female, as you mentioned. But also we should consider in some specific situations also the more classical immunosuppressive drugs, such as cyclosporine, azathioprine. In the last couple of years, if you look at the literature, there have been a couple of studies that showed again the high rate of response with azathioprine or cyclosporine in patients that have ITP, which is a ITP but a secondary form of ITP because it's together with another autoimmune disease like Sjogren disease, lupus, and so on. So I think that in this setting, we could still consider other immunosuppressive drugs, but in the second line.
Thank you, sir. Thank you so much.
Thank you, Dr. Malini. Dr. Ranjit Matthew Varghese, your question, please.
Good morning, Dr. Marco. Thank you so much for this wonderful lecture. My question is, what is your trigger for using TPO-RA in pregnancy? Supposedly, if a patient is there and we are continuously using corticosteroids, in the long run, corticosteroids is not very, what do you say, good for health. So,
yeah.
What is your trigger to use TPO-RA in pregnancy?
So this is a very important question because the current options during pregnancy are really scarce, and we still have corticosteroids. And I think that currently you cannot use TPO-RA, as mentioned, because they have not been studied during pregnancy, so we don't know about safety in this setting. So it's avoided to use them. But it is not available in Europe, and I think also in the US, but there is the recombinant human TPO, which is available in China, and it is very interesting because it can be used safely during pregnancy. I suggest to discuss very strictly with your patient because some ITP, if you have already the diagnosis of ITP, and the patient wants to undergo a pregnancy, you should discuss the possibility of pregnancy. Pregnancy is not contraindicated, of course, in patients with ITP, but a very good counseling with the patient is important because you know that pregnancy should elicit another recurrence of the disease. So it's very important to do very often the exams to check the platelet count. And you have to discuss with the patient that they shouldn't skip these exams. And another option that you can have during pregnancy, other than corticosteroids, you know that dexamethasone is the one that is preferred during pregnancy. You can consider IVIG treatment, for example. So currently, these are the only two options that we can use in this setting, and we hope that recombinant human TPO will be available in the future.
One more question I have, Dr. Marco. What is your trigger to use a whole exome sequencing or a next generation sequencing in case of ITP?
This is a very interesting question because as together with my group, I worked in Milan till 2 years ago. We presented an abstract at the recent meeting EHA in Madrid on the use of NGS in ITP patients. You know that there is a very interesting topic, because we think that some of these cytopenias, immune cytopenias, may represent a sort of pre-cancer situation. Some of these patients may evolve to myelodysplastic syndrome or other bone marrow failures. So there is a very important paper that came out recently on NGS in autoimmune hemolytic anemia. And to my knowledge, our work is the first one on ITP. So the paper, I cannot tell you anything more, but the paper will come out in the next few months, I hope. And we did perform in the last 5 years NGS in all ITP patients that were refractory to at least one line of treatment. And we showed that some of the polymorphisms that you may know, such as TET2 and NMT3 alpha, are more associated with evolution to myelodysplastic syndromes if we follow up the patient closely in the next future. So of course, it's just one study. We cannot say anything, but currently in clinical practice, I suggest not to test, but to consider it only in some specific patients. It's very difficult nowadays to tell you which patient. More evidence will come out and will help us to define which patients should undergo this kind of test.
So just sharing my experience, like we had one patient of ITP who was not responding to second and third line of treatment. So what we did was he developed hepatosplenomegaly en route during the course, maybe after going into the chronic phase. Then we did the NGS and it showed Niemann-Pick mutation. So subsequently a marrow analysis which was done, which was suggested.
Okay.
So that was the whole point of asking this question. So
if I can add something on this, because you mentioned Niemann-Pick, I think it's a different situation, because one situation is NGS to evaluate if there is polymorphisms in the myeloid genes that can predict evolution to MDS or other bone marrow failure syndromes. And another thing is the lysosome storage disease, because we know that platelet thrombocytopenia may be one of the hallmark of this kind of disease.
Yeah.
And I think that as a clinician, other than research, just as a clinician, we should all of us think about this kind of diseases and test for Gaucher, and of course Niemann-Pick if Gaucher is excluded, and other storage diseases, when the patient have the clinical triad of slight splenomegaly, thrombocytopenia, and hyperferritinemia. There are important reports on this topic, so some of us, sometimes we don't think about that, but as hematologists, I think that we should also think about that and just send the test, the blood draw, the dried blood test,
yeah, the DBS test,
to this kind of diseases. So thank you for the question, because it's a very important point.
Thank you so much, Dr. Marco.
Thank you, Dr. Varghese. Dr. Sonali Mohapatra, your question, please.
Good afternoon, Dr. Marco. That was a very good presentation, and especially with all the clinical trials and newer molecules. So my question is basic, like in upfront ITP, I'm a pediatric hematologist. So in upfront ITP, corticosteroids, so we can use dexamethasone as well as prednisolone. So I want to ask you, what is your experience with dexa and prednisolone? Now, how do you decide that where to use prednisolone or dexamethasone, and what is your experience on it?
Yeah, thank you for the question. It is another interesting point that we face every day in clinical practice. So far, all the clinical studies that have been performed didn't show any superiority of one drug to another. So they are equivalent in terms of efficacy, in terms of platelet response, and also in terms of sustained platelet response. So you can use both drugs as well. If you look at the toxicities, dexamethasone is has a slightly greater toxicity profile. So I would say that I would prefer dexamethasone in the elderly patients because we usually have concerns about about adverse events, and especially with high doses of prednisone. And in some cases, because we are afraid of these toxicities, we reduce the dose, and therefore we also reduce the possibility to get a response. So I think that even though there is no difference in the use of dexamethasone or prednisone, I would use in preference dexamethasone in the elderly, just because of this more safe profile, and with a different schedule, of course, that are different for both drugs. And I would like to highlight the fact that in the last guidelines, it has been highlighted the fact that the course of the corticosteroid treatment should not exceed 6-8 weeks of treatment. So we should always avoid to going ahead with treatment after this 6-8 times period. I hope I have answered your question.
So, like when we give dexamethasone like 40 milligram per day for 4 days, so if response is not there, would you like to repeat it every 4 weekly for how many cycles?
Yeah. You have to repeat at least for 3-4 times, and then you have to check the response. But again, with prednisone is 6-8 weeks all the time course, both the full dose and the de-escalation part. And with dexamethasone, you can repeat it for 3, 4, even 6 cycles. So it is more or less the same time of treatment, 6-8 weeks total.
Okay, thank you. Thank you.
Thank you, Dr. Sonali. Dr. Ashok Mishra, your question, please.
Hello, Dr. Marco. Thank you for very nice and very educative lecture on the ITP. So my question is regarding the CM313, which is a novel anti-CD38 monoclonal antibody, and recently Chinese study was published in NEJM June 1924. So I just want to your comment regarding this CM313 and how it is different from daratumab.
Yeah, actually, as you know, the study has been published a few days ago. So I didn't have the opportunity to participate in the study, nor me nor my colleagues. So I don't have more details than those that are presented in the publication. What I can say that the preliminary results are very interesting, as with all anti-CD38 antibodies, and I think that the most important thing of this kind of treatment should be really the long-term sustained response. There is a very high response rate, and this is a short-time treatment, and the patient thereafter seems to be off treatment, and we will see the long-term data, which will come out in the next years, but seems to be really amazing treatment for these patients. And I could say that if you compare this new drug together with the other two, which are daratumumab, that we all well know, and the other one, which is TAX-079, mezagitamab, with which I have some experience because I participated in a phase 2 study in Milan. These are administered subcutaneously, So this is for sure an advantage compared to the IV administration of the new anti-CD38 antibodies, but it could also be possible that in the future the company will develop a subcutaneous form also of this drug. So we will see. I think that the data are exciting, but we have to wait a little bit more to have more clear in mind what to do in the future.
Okay, thank you very much.
Dr. Marco, from the same note, if the patient has received daratumumab or that newer one that is mezagitamab, is it true that the CD38 internalization is more with these drugs as compared to the other one which is coming up, that is CN313?
Actually,
And
I
that is
have no
possible.
idea. Actually, I have no idea, and I don't know even if the authors of these studies have an idea on that. I don't know. I cannot answer on this question. I'm sorry.
Thank you. Dr.
I'm
Krishnanathan, your question.
I'm sure that data will come out also on this, because the resistant mechanisms are very important for new drugs, and we have more. We know much more in the last years that resistant and refractoriness to new treatments is a very important topic. So I think that the authors will will elucidate better this topic in the future. But no data so far, to my knowledge.
Thank you. Dr. Krishnanathan, your question, please.
Good morning for excellent talk. Good morning. Thank you for the excellent talk. I have two questions. For young females, do you routinely check antiphospholipid antibody for newly diagnosed ITP? And if so, is there any difference in the management?
Yeah, I didn't talk in this presentation. I didn't talk about diagnosis, because we decided with Professor Agarwal to talk about new treatments in this field. But it is a very good question, because during the diagnosis process, as we know, ITP is an exclusion diagnosis. So when you say to a patient that he is affected by ITP, we suppose that you have done all the other tests to exclude all the other kind of secondary thrombocytopenia. And within these tests, there is also antiphospholipid antibodies. So we are used to check at diagnosis the lupus anticoagulant, the anticardiolipin antibodies, and the anti-beta-2 glycoprotein 1 IgG and IgM antibodies. This represents the currently recognized antiphospholipid antibodies. There are also other, as you may know, in reporting in the literature, but so far they are not considered in clinical practice. So it is very important to always check these antibodies, because if you have antiphospholipid syndrome, for example, or a syndrome, of course, if you have the clinic to make a diagnosis of syndrome, but if you have these antibodies at high titer, and you exclude the ITP, so you don't have to treat the patients as an ITP patients. You have just to follow up the patient, and usually this kind of patient doesn't have real low levels of platelet. This kind of patients will not come with usually with 10,000 platelet count, but they usually have around 100. Maybe they could have 8,000 per microliter platelets. So this is a different scenario from ITP.
Thank you. The second question is, if you initiate a patient on second line thrombopoietin receptor agonist, how long do you continue, and is there a chance you can taper and stop it?
Another very interesting question. Thank you. And there are reports on the possibility to stop treatment. I didn't show anything on the current available treatment, because we decided to do so with this lecture. But anyway, there are reports on the discontinuation of TPRA, both for eltrombopag and remiplostim, and there are also published protocols to decide when you can stop the treatment and how you can taper the treatment. And usually these protocols suggest you to stop treatment at least after 6 months from starting. But from my experience, I would suggest to go ahead a little bit more, because we know that the rate of relapse of the disease is very high. So only around 30–35%, depending on the clinical cases, maintain the response after TPRA discontinuation. So even though the currently available protocol tell you to stop the treatment after 6 months, after at least 6 months, I would suggest you to stop a little further, to continue a little further, and to consider to stop these drugs only in patients that achieved at least a partial response, but better if you achieve a complete response, so platelet count greater than 100,000, sorry. And in patients that had a stable platelet count during treatment, because you have patients that stay in response but have very wide fluctuation during treatment. They come today and they have 60,000 platelets. They come the week after and they have 180 platelets, and the week after again maybe they have 55,000 platelets. So I suggest to really careful select the patient for which you want to stop the treatment.
And if you stop, do you gently taper or abruptly stop? I mean, how do you stop it?
Gently taper, and you can do on your own way, or you can follow. I suggest you to follow the published protocols, and of course you adapt this protocol to your patient. And take in mind, we should, especially in young patients, I think that stopping treatment still remain our goal, and don't be afraid of stopping if the patient relapses, because usually if you start again the same treatment, he will respond again. So, and nowadays we also have many other drugs available, so we don't have to fear if the patient relapses after stopping. So always try to stop, especially in young patients.
Okay, just a last question. When you start steroids for somebody and then they have very good response within a week, can you start tapering earlier, or still you have to give 6 to 8 weeks before tapering?
With drugs, sorry?
Steroids.
Steroid. No, it's better to do at least 3 to 4 weeks of treatment at full dose, because otherwise you may not achieve a sustained response after stopping, because you have to at some point block the production of these antibodies. So 1 week for sure will not be enough. So I suggest to go ahead for 3 to 4 weeks and then taper and stop stop after 6–8 weeks after starting. Don't go ahead after 8 weeks.
Thank you. Thank you so much.
Thank you, Dr. Karim. Dr. Nikhil Kumar, your question, please.
Excellent talk, Dr. Marco. You covered the topic comprehensively and so many advances in the field. It was a pleasure listening to you. I have a couple of questions. If a patient has a prior history of thrombosis, would you be very cautious in using TPO-RA, or would you avoid it? What is the thrombotic risk with TPO-RAs in your experience?
Yeah, it's a very nice question, because we all know that TPO-RA are associated with an increased risk of thrombosis, both venous and also arterial thrombosis, even if data are more lacking on the arterial part of the topic. But the different reports show a rate that is between 5 and 10%, depending on the clinical series. And so it's very difficult to decide. It depends, I think, on which was the trigger of the thrombotic event. So I think that we should very carefully assess the clinical history of the thrombotic event. And for example, if you have had a secondary thrombosis to, for example, surgery, mobilization, and so on, I think that we should be more safe. We can use the TPO-RA more safely. But if you have had an idiopathic thrombosis, and especially if the patient is a young patient, at some point somebody decided to stop the anticoagulant treatment, but you know that that patient, which is no more on anticoagulation, has had an idiopathic thrombotic event, I would be very careful to use TPRA. Of course, it's not a complete contraindication, but I think should be very careful, and always be very careful with dose modifications based on the platelet count response, because some patients respond very quickly, even after 1 or 2 weeks. So you have to carefully evaluate the blood count especially in the first month. And if the platelet count goes above 150, you have to taper, and if above 250, you have to stop. So carefully follow the instruction, which are very clear, to avoid possible thrombotic event. But it's a very nice question. And one more and last point on this topic: if you have a patient with an active thrombosis, should you avoid starting ITP, starting TPRA if needed? I would say no, because if you are on anticoagulation, you are already protected against thrombosis. So and if you need to control the platelet count, which is very important, especially in patients that are anticoagulated, and you want to have a platelet count above 50,000, it's more important to have this platelet threshold above 50,000 to go ahead with anticoagulation. So in this case, I would start the TPRA without any fear.
And among the TPRAs, is the thrombotic risk same with romiplastim and eltromopad?
Yeah, it seems to be the same across all the 3 different TPRA available in Europe, and because it's a class effect, you know, so there is no difference on the incidence.
And I would like to discuss one of my patients with you. We have a young male patient, 30-year-old, who is a known case of APLA. He has a history of pulmonary thromboembolism 4 years back. Currently, he has presented with thrombocytopenia and he has secondary ITP. There is no other manifestation of APLA at present, no end organ damage, no fresh thrombosis. He was on anticoagulant, but his platelet dropped to 12,000, so we had to stop it. So in this patient, after giving IVIG and steroids, there was no increment in the platelet count. So how would you proceed? What would be your choice of agent for this patient, considering he has a secondary ITP with an underlying APLA?
Okay, sorry, under what? Which is the
underlying antiphospholipid syndrome, APLA.
Okay, sorry, okay. It's always difficult to give advice on this situation. So you have the thrombocytopenia is considered to be secondary
ITP. We have done a marrow. We have ruled out the other causes, so it's considered to be a secondary ITP. He has an underlying APLA.
Okay.
He has a history. He has chronic pulmonary thromboembolism.
Okay.
Currently, there is no new event apart from the ITP.
Okay, so now it's more clear. So if the patient has APLA and he had a thrombosis, I suppose that it's still anticoagulated.
Yes, he was on anticoagulation, but now his platelet count has dropped to 12,000, so we had to stop the anticoagulation.
Okay, and this drop on the platelets is for sure a secondary ITP. You have, I suppose that you have excluded all the other causes possible, right?
Yes, we have.
Okay, so in this case, as we said before, you need to increase the platelet count because you need to go ahead also with anticoagulation in this patient. So as a second-line treatment, why not using a TPRA? Of course, you have concern about the antiphospholipid syndrome, but if you are fully anticoagulated, you can do that. Or maybe you can also consider, I don't know which drugs are available in India. I have no idea. I'm sorry about that. You can teach me about this, but maybe you can also consider other immunosuppressive drugs, because if he has antiphospholipid antibodies at the same time, maybe to target the immune system in this situation may be more helpful than targeting the megakaryocyte with TPRA. So if I would have to choose, maybe I would choose another immunosuppressive line of treatment, for example, rituximab, if available, or depending on the fact that if the patient has other autoimmune diseases associated, you can discuss together with the rheumatologist or the immunologist which is the better option. But you can still consider the classical immunosuppressors such as azathioprine, cyclosporine. They are very helpful in this situation. So if I had to choose, I would choose another immunosuppressive line of treatment before, and I would skip the TPRA. They're not contraindicated, but I would use them in a later phase of the disease if I cannot achieve any response with the immunosuppressive drugs.
So if the TPRA is not working, you would consider for rituximab, cyclosporin, the classical immunosuppression should be tried in this patient.
Yeah.
Just one last question, Dr. Marco. Many of the elderly patients who present with thrombocytopenia, we routinely do a bone marrow examination to rule out a myelodysplasia. While many of them don't have a marrow change, but it's not uncommon to detect a clonal mutation in these patients. So in this scenario, would you treat them differently? If patients have thrombocytopenia and a clonal mutation, but no other evidence of MDS, no other cytopenia, would you treat them differently, or would you still treat them as an ITP?
Yeah, very interesting question. And to the current knowledge, I would say you have to treat the patient as an ITP. And just to tell you which is our clinical practice, we don't perform bone marrow biopsy in first line. I mean, if the patient presents with ITP and we do all the tests and we finally diagnose an ITP, we start the first line treatment with corticosteroids and we don't perform any bone marrow biopsy. If the patient recurs and it's an elderly patient, this is more true for elderly patients than for young patients. But before starting the second line treatment, we consider always to perform a bone marrow biopsy. I don't say that I always do that before starting the second line, but in most cases, also considering the other conditions, all other exams of the blood count, I prefer to perform a bone marrow biopsy. If I find, of course, a myelodysplasia, the patient will be treated as having a myelodysplastic syndrome. But if we only find we have a normal histology, a normal morphology, a normal karyotype, a normal fish, but have some mutations that we found in NGS panel that we now, all of us, perform NGS panel, myeloid NGS panel in all these kind of patients because of research, but also because of clinical needs. If we only find some polymorphisms in myeloid genes, you don't have to change your clinical practice. The patients still have ITP. What I do, but current guidelines doesn't recommend to do so, is I follow with NGS the patient, even on the peripheral blood, over time. Not often, but maybe after 2 years, or if I see a modification of the blood count. You remember that this patient also has a mutation in the myeloid gene, so it could develop in the subsequent years a myelodysplastic syndrome or bone marrow failure syndrome. So if you do the NGS panel and you find some mutation, don't change your clinical management of ITP, but consider to change the follow-up of the patient in the subsequent year, depending on the evolution. That's my feeling on this topic.
Thank you so much, Dr. Marco.
Thank you, Dr. Nikhil. We have some questions from the chat box. So Dr. Manthan wants to know, how much is the maximum dose of L-thrombopag and romiplostim do you use?
Okay, so according to the prescription for L-thrombopag, the maximum dose is 75 milligrams in ITP. We know that it can be increased to 150 milligrams for aplastic anemia, and for romiplostim is 1 milligram per kilo. So you start with low doses as 25 milligrams for L-thrombopag, 1 microgram per kilo for romiplostim, but according to the prescription, but in this case, in the case of romiplostim, I would suggest not to start with 1 microgram per kilo because it's really low amount, and I've never had a response with this dose. So I would start with 3 microgram per kilo for romiplastim against the indications, but you can reach the maximum dose, and in some patients you need to reach the maximum dose. If I don't know if avatrombopag is already available in India, but avatrombopag Doptelet it's a new generation TPRA which has been recently approved in Europe and in the United States, and it has the advantage that can be that has a higher efficacy. So if you don't have a response to eltrombopag or romiplastim, you can switch to avatrombopag and you still get some responses. So it's and with this drug you start with 20 milligrams and you can get up to the maximum dose of 40 milligrams a day.
Thank you. So another question is, when do you plan to add ATRA, and how do you temper the combination of ATRA plus TPO?
Actually, never. I mean, because there are no data on ATRA use. It was just not even a post. It was just an abstract that was presented at EHA last week. So, to my knowledge, it's the first time that ATRA has been considered. And of course, the results are only on, if I remember well, on 13 patients, but are interesting. And we will see in the future if we'll add something on current practice. So it's too early. Don't use ATRA, please, in ITP so far.
Thank you. Another question from Dr. Dinesh. What would be the starting dose of prednisolone? 0.5 mg per kg or 1 mg per kg?
The current guidelines says from 0.5 to 2 milligrams per kilo every day. I usually start with 1 milligram per kilo. I reduce a little bit the dose in the very elderly if I don't decide to use desamethasone, for example, as I said before. And you can increase the dose to the maximum dose of 2 milligrams per day, maybe in patients that also have concomitant autoimmune diseases, so you want to be more aggressive on the immune system.
Thank you. Another question from Dr. Dinesh. Is it safe to use TPO mimetics in a patient who has got triple positive APLA with thrombocytopenia?
Which drug, sorry?
Is it safe to give TPO mimetics in a patient who has got triple positive APLA with thrombocytopenia?
Again, difficult question to answer, but if you have triple positivity and the patient is not on anticoagulation, I would be very careful to use TPRA. It is not a contraindication, again, but I would be very careful. If the patient has antiphospholipid antibodies, as we said before, and is already on anticoagulation and have no other options, because I have tried all the immunosuppressive strategies and I decide that no more immunosuppressive treatment is necessary, I think that we can use also TPRA, because we are protected against thrombosis because the patient is anticoagulated. But you have to be very careful and closely monitor the patient and advise the patient about which are the symptoms of thrombosis, so that if the patient is aware, he can rapidly refer to the doctor if some of these symptoms occur.
Thank you. From the same note, if the patient has undergone is a case of coronary artery disease, as an undergo angioplasty or bypass surgery, is it safe to give TPO mimetics in such patients who have got coronary artery disease?
To coronary artery disease?
Yes, patients with coronary artery disease with thrombocytopenia who develops ITP. Is it safe to use TPO mimetics in the patient who got
the answer is similar to the previous one. I think that if the patient is on anti-aggregation, you have no other options, so you can use it. I have had the experience of many patients that had undergone coronary angioplasty or even myocardial infarction. I remember well a patient that had a massive myocardial infarction with ITP, and he had 2 cardiac arrests. And even though that was the case, we decided collegially to prescribe TPRA, and so far we did have no problems. Of course, we have to be very careful in managing well the dose based on the platelet count. Especially in these patients, you don't want the platelet count to go to 500,000. So be very careful, but if you need it because you need to increase the platelet count, you can use it also in this setting.
Thank you. Another question from Dr. Mainul Islam. In post-COVID situation, we have seen that asymptomatic thrombocytopenia occurs with an average platelet count of 50K to 100K. So what will be the next plan in such patients post-COVID where the platelet count remains between 50K to 100K? Would be just observation, or would you need to do something? Say, for example, you want to give low-dose steroid for short duration, which will be beneficial.
Okay, it's a complicated question. I don't know if I have get well.
So
Could you
post-COVID
summarize it a
patient-
little bit?
Yeah. Post-COVID patients who develops moderate thrombocytopenia between 50K to 100K. Should we observe these patients, or should we go for low dose of steroid for short period of time?
For sure, observation.
Versus observation.
Not only for secondary, because this is secondary thrombocytopenia. Okay, you don't need to treat secondary thrombocytopenia associated to whatever, in this case to infections. We know that viral infections are frequently associated to transient thrombocytopenia, and you don't need to treat as ITP these patients, and more generally, even in ITP patients, you don't have to treat always the patient. So I didn't talk about that because it was diagnosis, but current guidelines advise us to start treatment only if the platelet count is below 30,000 or 20,000, depending on different guidelines, or if the platelet count is less than 50,000 and you have active bleeding. So these are the only situations in which you have to start a treatment for ITP. But for secondary ITP, especially during infection, I would not treat the patient. He has 5,000 platelets, and then do something to prevent bleeding.
Thank you. Another question from Dr. Bhavani. If a patient has got robust response with platelet count rising to about 10 lakhs on starting steroids within 1 week, is there any need to taper immediately, or should we continue till 4 weeks and then taper to prevent the relapse? And if it is more than 10 lakhs, do we need to add antiplatelets like aspirin when the platelet count rises to more than 10 lakhs with steroids within 1 week?
Oh God! Again, it's a bit difficult to follow you on these clinical cases.
So
I cannot see the writing right
Yeah.
now. Sorry.
Dr. Bhavani has a question. If a patient has been started on steroids and the platelet count rises to about 10 lakhs within 1 week, do we need to taper the steroid or stop the steroid immediately?
Okay. No. You need to go ahead. You need to go ahead a bit more, because otherwise you risk to not obtain the sustained response after you stop the treatment. So in this case, I would use I would not go ahead 3 weeks, for example, but at least you have to do a couple of 3 weeks of treatment. Otherwise, you lose it's like losing the first line of treatment.
So if it rises to
when
more than 10,
when the platelet count goes too up, I mean above 1 million, be careful. Be careful, because you know that in some situations you can develop acquired from Willebrand disease. So be careful of adding aspirin. It's not that common to have such a response, and I would say maybe we should reconsider the diagnosis, because it's true that ITP usually respond very quickly and very well to the first line treatment, but such a good response is not that common. So I would also reconsider the diagnosis. I'm not saying that it's wrong diagnosis, it could happen, but I would be more careful in this patient.
Thank you so much, sir. Dr. Bhuvesh Gori, your question, please.
Thank you, Dr. Marco and Dr. Amit. You've answered a lot of questions already.
Can you please be loud, sir, because we can't hear you. Little bit closer to the mic. Yeah.
Thank you both. It was very interesting to hear the discussion. It was more to share our experience, whereby we have had 2 patients with catastrophic antiphospholipid syndrome. One we started here at our institution because she was on anticoagulation and had low platelets. And another was started on L-Trombopac, was a 27-year-old, started at a different institution and came to us for plasma exchange and renal support. And both of them had high titers of antiphospholipid antibodies. And since then, we have been very careful to start them on TPR antagonists and trying to screen every patient for antiphospholipid antibodies. So thank you for that. And but they responded very well to immunosuppressant afterwards, as a tyrapine, for example.
Great. Very glad to hear same experiences on that. Thank you.
Thank you, Dr. Bhuvesh Gauri. Dr. Ranjit Matthew Varghese, do you have another question?
Yeah, thank you, Doctor, to allow me for one more question. Dr. Marco, I have one question. How do you tackle a patient of ITP who has failed multiple lines of treatment, ends up getting a splenectomy? Post-splenectomy, after 3 months, he again loses the response. So is it the same way you go around, or is it something different? What is your experience in such kind of cases?
In the past, we had much more experience on patients that underwent splenectomy, but you know that in the last 10 years, at least in Europe, we don't perform anymore splenectomy. We still perform splenectomy in some really specific situations, but nowadays the experience on this kind of patients is becoming less and less important. So I don't have a good answer for your question, but I would consider, if available, the enrollment in a clinical trial for these kind of patients, because if you have used all your options, and you can try to retreat the patient with maybe you can reconsider the history, the clinical history of the patient. You can look at the duration of response and the duration of response with a different treatment, and you can choose to retreat the patient with the drug that was associated with the longest response. You can try that. But if you have an available clinical trial, or you know some center, if you don't have the clinical trial and you know some center nearby that have an active clinical trial, I think that these patients should be proposed for enrollment. And in some situation, it depends, but in some, for example, in Switzerland, it's more easy than in Italy. In some situation, you can also use drugs in an off-label setting. I have had already the opportunity, not in ITP, but I have already the opportunity in these 2 years in Switzerland to use drugs that are still under evaluation in phase 3 clinical trials, and the company and the insurance after allows you to use these drugs even before the approval by the agency. So if you don't have a clinical trial, there is no other possibility for the patients, and you clearly explain this to the insurance and to the patient, to the company, you can also get access to these drugs. But I suggest to enroll the patient in a clinical trial.
Thank you so much.
Thank you, Dr. Varghese. Dr. Krishnathan Kannan, you have another question? Dr. Kannan? Fine.
In the frontline treatment, when somebody presents with severe thrombocytopenia with short steroids, when do you decide whether the patient also needs IV immunoglobulin?
Yeah, I think it depends on the presentation. If you have a patient with a bleeding diathesis that is happening, I want to have to increase the platelet count as soon as possible. So in some situations, I would also consider to combine immediately the two strategies. So I start together corticosteroids and IVIG. And depending again on the severity of the bleeding, we can decide which of the two approved schedule of IVIG administration to use. And in this situation, for example, I would use the 2 days infusion with high doses. And while if you have a patient that doesn't have any active bleeding, even if the platelet count is very low, namely 20,000, 15,000, you can consider just to monitor closely the patient and only use steroids. But it's all, I think that it also depends on the confidence that us as a physician have with this situation. So if you feel more confident to have a greater increase in the platelet count and more rapid one, why not using both strategies altogether? I think that we need to be, as a physician, comfortable with the decision. And so in some situation, I think that we can maybe increase a little bit the intensity of the first-line treatment. Not to exaggerate, but we can.
Is anti-D out of fashion now? RH anti-D immunoglobulin, which was used before. Is it gone now?
Yeah, it is. It has never been approved in Europe, so I have no experience. I mean, in Italy, sorry, because I know that there are some countries in Europe that can use it, maybe Germany or Austria, something like that. It is more widely used in the United States, but I have no direct experience. So the only thing that I know is just from books, from literature. So no direct experience. I don't know if in India you still you use it or not. It is approved.
Very
No, I
few
have
centers.
not used it.
Okay.
Thank you.
Thank you. Thank you.
Any discussions want to ask? Any other question? Well, and so there are no more questions in the chat box. Well, sir, thank you so much for that fantastic and excellent talk. And what a wonderful discussion we had with you. Thanks for joining us as our speaker today. It was always good learning from you. Thank you so much. What a great knowledge.
I've been very grateful to be with you today, as in the past, and I hope there will be other chances to be together in the future.
Sure, absolutely, sir. Thank you so much, sir. Thanks a lot.
Bye. See you.
Bye.
Bye-bye.